there. This is your favorite nurse practitioner, Patty Anderson, and I'd like to discuss first-generation anti-obesity medications using AI technology, naturalreaders.com, to talk about these overlooked gems for obesity treatment in this presentation from Medscape Medical News. Now let's begin. So with the explosive popularity of glucagon-like peptide 1s, also known as GLP-1 agonists, physicians say a key avenue in treating obesity is being underutilized by many clinicians. First-generation anti-obesity medications don't get as much attention as the newer ones, according to obesity specialists who say they're fantastic. They just get overlooked. Older anti-obesity medications typically cost less than GLP-1s, are more accessible, and often have low risks, but patients frequently ask for the newer medications, and some doctors don't access their full treatment toolbox before prescribing. Currently, there are 6 anti-obesity medications approved by the U.S. Food and Drug Administration for chronic weight management. Orlistat, Phentermine topiramate extended release, Bupropion sustained release naltrexone, liraglutide, semaglutide, and tirzepatide. The first 4 medications are considered first-generation anti-obesity medications, according to a 2024 analysis in Diabetes Spectrum, a journal from the American Diabetes Association. The advent of new anti-obesity medications has transformed the treatment of obesity, and for the first time, there are now second-generation medications whose outcomes can rival those of bariatric surgery. However, first-generation anti-obesity medications serve an equally important and enduring role in the treatment of obesity. Whether because of insurance or supply limitations, costs, patient preferences, tolerability, or safety, patients may require a first-generation anti-obesity medication, and providers must feel comfortable prescribing them. Are you a good candidate for a first-generation anti-obesity medication? One group of people who may benefit from a first-generation anti-obesity medication is someone whose treatment goals include losing a moderate amount of weight, said an obesity medicine and family physician specialist. Older anti-obesity medications are generally appropriate for patients in whom about a 10% loss of body weight would be an adequate result. If a person needs to achieve 20% or more loss of body weight, physicians may want to jump straight to a GLP-1 like Wegovy or Zepbound. For example, patients who are planning knee replacement surgery or those with a higher body mass index considering weight loss surgery would be good candidates for GLP-1s. When appropriate, clinicians usually follow a stepwise approach to treatment. For example, I might start a generic medication like Phentermine. If it is not tolerated or I do not see the amount of weight loss needed to improve obesity complications, I would transition the person to a branded oral medication like Contrave, Qysmia, or maybe switch to and/or add a GLP-1 like Wegovy or Zepbound. First-generation anti-obesity medications may also be a good choice for someone with certain comorbidities, like chronic headaches. Some people with a history of migraines or individuals who have polycystic ovary syndrome may benefit from topiramate, while a Phentermine topiramate combination may help with appetite suppression and impulsivity modulating. The latter can be useful for patients with nighttime eating syndrome and binge eating disorder. In addition, Bupropion naltrexone can be beneficial for patients with depression and anxiety and may help with smoking cessation in patients with smoking habits. Obesity, as you know, is not one size fits all. It's not just about BMI. It's about tailoring the therapy depending on what other comorbidities you have. That's why it's always good to lay down all the tools and discuss what will benefit you in your specific circumstance. The lower cost of first-generation anti-obesity medications also makes them good options for many people, obesity specialists say. Even with pharmaceutical savings programs, GLP-1s usually cost about $499 per month or more for the medication, excluding the consultation. By contrast, Contrave costs about $99 per month directly through the savings program Cure Access. and Qysmia is generally available through Qysmia.com for about $98 a month. As a board-certified family medicine clinician, I once treated a 45-year-old man with Class 2 obesity and high blood pressure who was unable to access GLP-1s through his insurance, despite several prior authorization attempts. Rather than attempt a new prior authorization, I started him on a Phentermine topiramate combination, which worked well and led to weight loss of about 30 pounds. Since Phentermine is a stimulant, I closely monitored his blood pressure, and ultimately, my weight loss strategy also led to better management of his hypertension. People who are non-responders to GLP-1s or who have difficulty tolerating GLP-1-based therapies may be good candidates for first-generation anti-obesity medications. These older medications may also be good choices for patients with lower BMIs and in cases where second-generation anti-obesity medications may be too powerful. Age should also factor into the decision of a weight loss medication selection. Wegovy, Saxenda, and Qysmia are approved for patients as young as age 12 years, while other medications are only indicated in adults aged 18 years or older. What are the risks of first-generation anti-obesity medications? Well, it's important for me, as a clinician, to know my patient and be sure there are no contraindications before prescribing older anti-obesity medications. For example, your primary physician will probably avoid prescribing Phentermine in someone who is sensitive to stimulants like caffeine, someone who suffers from severe insomnia, or someone who has complicated hypertension. The three most common side effects of Phentermine are dry mouth, constipation, and trouble sleeping. Individuals can usually get around these problems by modifying their dosage, taking a stool softener, drinking more water, and not taking the medication in the evening. Contrave, meanwhile, should be avoided in people with a history of seizures or those on opioid pain medicine. Qysmia should not be prescribed in patients with a history of kidney stones or at risk for pregnancy because Qysmia can cause birth defects. If someone does not have a contraindication or other concern, by all means I would recommend using a first-generation obesity medicine. Keep in mind that all anti-obesity medications can cause gastrointestinal side effects and could lead to gastrointestinal upset. Orlistat, for example, has really fallen out of favor due to minimal weight loss and way too many side effects. I often do not prescribe Orlistat because of the side effects, which include an oily discharge and unexpected greasy stools. Who wants that? Let's dispel some fears about sympathomimetics. I really want to emphasize the importance of dispelling misconceptions surrounding first-generation anti-obesity medications. Because the drugs are in the stimulant category called sympathomimetics, there has been concern, even among clinicians, that patients could become addicted to them. There have also been worries about the medications raising patients' blood pressure. There's a lot of fear around sympathomimetics medications, which is ironic, because clinicians will prescribe Adderall for 6-year-olds and won't be worried about it at all. There is data on long-term use of these medications, and there is data on side effects of these medications. Clearly, older obesity meds are not for everyone, but they certainly are fairly benign in terms of risks. Sympathomimetics get a bad rap, but they are really good medications for a lot of people, and many people do well with them. I will add that older anti-obesity medications have stood the test of time and proven their value, which is something the newer medications still must do. Medication choice should always be matched with a person's individual risk factors, goals, and access. It is critical to set realistic expectations and incorporate these drugs within a broader framework when considering behavioral, nutritional, and lifestyle interventions. As always, feel free to reach out to me, your favorite nurse practitioner, Patty Anderson, for a free consultation about prescriptions. Reach me at nursepatty@gmail.com. Tata for now.